Hi. This presentation is brought to you by St. Mary's Hospital for Children, Clinical Systems Integration with Alarm and Notification. My name is Bensi Massinello. My co-presenters are Nancy Day and Janet Fellini. St. Mary's Hospital for Children is located in Bayside, Queens, New York. It is a non-for-profit pediatric healthcare system. We began serving children in 1870 with a 15-bed hospital in New York City. In 1951, a 97-bed inpatient post-acute facility was constructed in Bayside, Queens, New York. In 2012, we opened our new state-of-the-art patient pavilion with 103 beds and added 21 more respiratory care beds in 2019 to our census, which totals up to 124 post-acute care pediatric skilled nursing beds. As a health system, we serve over 2,000 kids within our New York metro area in our inpatient, home care, and outpatient programs. We typically have children that are medically fragile with a lot of medical complex needs that require post-acute skilled care. The objectives of this presentation is to showcase the reduction of non-actionable patient bedside alarms, which were sent to RNs on their handheld notification device. Is to analyze patient-specific alarm parameters on patient monitoring devices based on their medical orders, and to reassess new technology and alarm management to decrease alarm fatigue among caregivers on the units. An overview. Alarm reports were done in our middleware for all admitted patients on one of our patient unit, so 3 children's unit, for a 3-day period in the month of May in the year 2021. These reports showed specific alarms from the patient monitoring system, such as low saturation, pulse oximetry, low pulse rate, and/or high pulse rate. We reviewed the alarm data with the nursing team and the assistant nursing director of the unit, who then brought specific findings and trending to the medical provider. After review by the medical provider, multiple alarms and observation orders were modified in the medical record. The alarm data was then repeated, the same type of report mentioned above, for another 3 days in September of 2021 to compare a pre and post analysis. The comparison data was only done for the children who were actually present on our census both in May and September of the year 2021. The first display here shows the low saturation alarm on the 3 CU unit, which the trending in May versus September, which shows an improvement in terms of having had a total of 512 alarms generated in a 3-day period for low saturation to a total of 340 alarms in September for the same alarm type, which is low saturation. This slide speaks to the comparison data in May versus September, but for the low heart rate. So we see that there was a total of 271 low heart rate alarms that were generated and notified the nurses on their handheld phone, which then in September, with all the modifications made to the parameters and orders, decreased the low heart rate alarms to be at a 79 total in September. Again, marking an improvement of number of alarm notification. The third alarm compared in the same manner is high heart rate. We see that there were 93 total high heart rate alarm in a 3-day period on the 3rd floor, which then reduced with interventions to 23 alarms for the 3-day period in September on the 3rd floor. In conclusion, overall, the number of alarms, each of the alarms compared here showed a marked decrease. Low saturation on the whole unit decreased by 66%. Low heart rate decreased by 29%, and high heart rate decreased by 24%. This initiative and project also increased collaboration between medical providers on the clinical unit, the respiratory therapists, and nursing leadership and nursing staff. We utilized reporting from the bedside monitoring system, our middleware that connects our bedside monitoring system, alarm notification to a handheld notification system for our nurses. This project concluded that RN received less notifications onto their handheld device when interventions were made based on data analysis. Thank you.